first I'd like to thank Dr. Rishi for giving me the opportunity to present in this IC. So I'll be talking on GRT. I don't have any financial interest. Now, this is the photograph of the surgery to have a retinal attachment with GRT like this and to have a conversion to attach retina post-operative period. So if we just go through the few initial information, it's a retinal break that extends more than anteriorly with posterior vitreous detachment, and it's a cause of retinal detachment in 0.5 to 8.3% of cases. There are reports of its annual incidence of GRT. There is a male preponderance, right eye is commonly affected, and you all know about the landmark study by Dr. Freeman, reported 12.8% of bilateral GRT at 16 years follow-up. There are two challenges which we'll describe along with the videos. It's most commonly seen posterior to ora, around 82% of cases, followed by equator and posterior to equator. It's most commonly idiopathic, it's around 55 to 60% of cases. It's traumatic, followed by traumatic hereditary retinopathies, myopia. There are a lot of iatrogenic complications, especially in cataract surgery, while to recover the lens, drop nucleus, intraocular foreign body nephropathy, LASIK, and few other conditions in aniridia, coloboma, retinal pigmentosa. So the pathogenesis in GRT, we usually have a very abnormal retina and vitreous liquefaction, and it starts with circumferential vitreous traction causing anterior taut membrane, which actually makes retinal ridge adjacent to the area of file without pressure. The straight retina rips and forms GRT at the base of the pupil. It extends very fast, and that's more important in case of GRT to reach when 360 degree within weeks. I'll just go shortly through clinical features. Mostly the patients present with dimness of vision within 10 days, and this is more important. More than 50% of patients with GRT present with PVR grade B during presentation. Now, if you're not able to visualize the fundus, you can do ultrasound, and the characteristic double linear cosine can be seen here. So there is absence of retinal echo in at least one quadrant corresponding to the GRT, and you can view the anterior flap. You can figure rotating the transducer. So preoperative evaluation, apart from extension of the retinal tear detachment, assessing choroidal detachment if any, and extension and severity of the PVR, we need to see whether there is vitreous attachment and mobility of the posterior flap and clarity of the media. Examination of the fovea is very important, and as along with the patient selection and counseling. So macular detachment, aphakia, hypotony, poor preoperative visual acuity, advanced PVR, and more than 180 degrees are usually associated with poor visual outcome post-operatively, and definitely the extensive dissection during surgery, relaxing retinotomy. So we come with a decision about to bring buccal or vitrectomy, vitrectomy with or without encirclage, lens sparing or lensectomy type of tamponade. So we'll just discuss along with the steps. So buckling, it's definitely advantageous to be having one quadrant of GRT with no PVR. Adequate treatment of the flaps and lateral horns can be done with cryo. Mild grade of PVR with star pose in one quadrant can be managed, and we need to have a low broad buckle and support the star pose, because there are always disadvantages of buckling. To have fish mouthing, to have retinal slippage, distortion of the globe intraoperatively, retinal folds and recurrence. So vitrectomy is mostly indicated mostly surgeons are managing with vitrectomy, with GRT, and it's indicated in severe PVR, in GRT more than 180 degree, and trauma, in lens dislocation, intraocular foreign body, and vitreous hemorrhage. This patient actually was having a large tear more than 270 degrees attached to the middle part as like a stop, and so there is no other option of doing anything other than vitrectomy. So encircling band usually preferred if we are not doing a 360 RF. So it's preferable in phakic eyes in cases of advanced anterior PVR to support the edges of break, but the inferior breaks also. But the complications and the disadvantages are same as putting buckle. Lensectomy IOL removal is indicated if you are having anterior PVR, cataract changes, peripheral PCO falsification, lens or IOL dislocation or subluxation, and trauma. So the pulse of doing vitrectomy, You have to do a thorough vitrectomy with maximum removal of the base. So doing vitrectomy with removal of the anterior vitreous, and we go to the lateral horns. You can see the fold here. You can see the fold here, and we are replacing the lateral horns and the inferior horns, and we're doing a saving and base excision in the tensional part as well as in the part of the attached retina. So complete vitrectomy at horns of GRT and edges of tear. So this was actually operated bimanually to have a better view of the video, and sometimes you can do cryo also at the edge if you are having very anterior GRT where you need to localize the flap. So the difficulty is that in case of GRT managing, sometimes we get a few vitreous fibrils attached to the posterior retina despite the PVD, and sometimes removing that one or trying to remove that one, and sometimes we can have very high mobile retina and can have iatrogenic breaks. So this patient, there are few vitreous fibrils in the posterior flap. You can see very high mobile retina and great iatrogenic break here. Managing the PVR in case we immature preretinal membranes, we can stain with the ADT and spatula and forceps, we can remove the membranes, but difficulty identifying the membranes always leads to incomplete removal. Mature or subretinal membranes can have bimanual dissection, but iatrogenic break, residual traction, large retinotomies are having their own disadvantages. You can have choroidal injury also during if you are trying to remove subretinal membranes. There is managing PVR, but this patient was vitrectomized elsewhere for endophthalmitis, presented with presumably mobile retina with almost 270 degree of diagonal tear. So there are a few subretinal membranes here, which you can need to assess initially that to remove the subretinal membranes. And once you feel that it will be okay, you can try to have some amount of posterior fold PFCL and see whether the retina is flattening. But this amount of folds, these folds will be able to recognize once you put PFCL. Try to flatten spatula, it's not going. So again, you have to reduce the amount of PFCL, go subretinal space, and remove the membranes at whatever extent possible. Then again, you put PFCL. So using PFCL, see, injection should be very slow, should be over the desk. Rapid injection usually leads to a lot of bubbles, subretinal bubbles. Cannula tip should be always inside the bubble. Infusion, you can put semi-off, and you can see the color of the disc changing during putting PFCL. So the CLA pulsation monitoring is very important if you're putting PFCL, and should be always slow. You can tilt the globe towards the end of GRT to flatten it with the PFCL. And you should avoid hypotony because the possibility of folds, possibility of subretinal migration of PFCL is more if you are having hypotony. And PFCL should be always above the level of the tear. But sometimes we get a lot of patients where there's a possibility that during PFCL we can have a iatrogenic macular rotation. So flap of the retina, attached retina, can be kept till the end before we cut it. Managing the anterior and posterior flaps will go according to the videos. This patient was having that first video. This at the equator, so you can see two bands. These are the anterior flaps which are removing along with the vitreous. So anterior flaps has to be excised as much as possible. And if it's phakic, it's okay. If it's phakic, then definitely with depression, we have to remove as much as anterior flap. Redundant flaps. Posterior flap in the same patient, you can see a lot of curling and rolling of the lateral edges. So under PFCL, you can try to gently stroke with the spatula. You can try to flatten it. You can put little more amount of PFCL, and subsequently you can try to flatten the retina by gently unrolling with the tears. But compared to this patient, this young patient was having reasonably okay with no PVR changes. So once you have done good vitrectomy, you're putting a PFC, you can flatten the posterior flap nicely. Do extends more to the anterior part. This another one patient, the same patient where we have put more PFCL and then we are planning to do the black retinotomy. So very careful when you cut her because you can have iatrogenic coronal bleeding, such as this one. But in this patient, very young patient having a large posterior tear, subretinal heme, IDT was used to induce PVD, and then it was lasered under HG. The lips is not required in this posterior large tear. Now retinopexy, 360-degree laser shows an anatomical reattachment rate of around 90% in several studies, and we prefer to do 3-4 rows of staggered pattern of extension and laser, an extension to the horns, supplemented barrage if we get a persistent SRF in patients. But in phakic eye, anterior treatment can be done even with indirect ophthalmoscopy, laser indirect ophthalmoscopy, because with TSC, most of PVR rate is more if the GF is more than 180 degrees. So this was the patient having laser after we have flattening on the PFC, the peripheral edge of the posterior horn. Recurrent RD in eyes with silicone oil tamponade was less than gas, 12.5% was 31.1%. Post-op complications are comparable in studies. Risk of anisometropic amblyopia in children with silicone oil injection is to be kept in mind. There was no difference in outcomes between the two groups, which was done in the Lipschen study, Lipschen and gas, in terms of retinal detachment rates, 38% Lipschen versus 49.4% overall. So once we start the PFCL silicone oil exchange, we have to start with, after removing the anterior fluid, once we start putting the oil, then remove the rim of fluid between the oil and the PFCL meniscus. I'll show you in the next video. And keep the tip in anterior PFCL meniscus. PFCL removal in anterior to posterior direction, and fluid tip of GRTH to flatten and dry the anterior retina. So this is the meniscus. It's not visible properly. This is the meniscus of PFCL and during exchange. We're just removing the fluid first, and then you be in the center of the PFCL with the fluid, be over the disc, so avoid inadvertent trauma to the retina, and you can remove the whole PFC over the disc.
So can you try to conclude fast? You're running short of time.
So anatomical primary retinal detachments are between 77 to 94% with partial vitrectomy alone, and between 68 to 96% with combined with buccal. And functionally BCD improved to, in 50% of patients in most studies, and deteriorated in at least 40% of cases when compared with the presenting vision. It was in British JAMA epidemiological study, it was 42% of patients that had BCD of more than 20/40. Out of these complications, I think TSP, extension, rotation of flap. This was a patient, we had a choroidal hemorrhage, and this patient had a recalcitrant retinal fold even after surgery. Post-operatively, we can have redetachment with BVA, inferior BVA, and we have had barrage this patient. Cataract, increased hypotonic, and sometimes subretinal PFC, which can be very dangerous. So fellow eye, I just conclude that there is still no evidence to support or refute the use of 360 prophylactic treatment in fellow eyes of GRT. In only Stickler syndrome, we have a prophylactic laser which may benefit, helpful, and still there is no consensus on the need of prophylaxis and where to treat. There is an advances. I think after that, most of us are trying 23 and 25 to take them. Adjuvants in managing PVS, steroid, anti-metabolism, or using your antigens, TGF, beta, ETGF. Thanks a lot.